So this is your scenario. Kindly review it and then we will start.
Okay.
Okay. So what is the most common malignant cancer for gallbladder?
Okay, the most common one is adenocarcinoma.
Okay. So can you name some risk factors?
Okay, risk factors include gallbladder stone, age greater than 70 years, female gender, recurrent cellular type, and infection. There's some races of American South America.
Okay. Anything else?
This is porcelain gallbladder, polyp of the gallbladder, and also umbilical cyst.
Okay. So can you tell me about the spread of the cancer gallbladder?
Okay, the spread of gallbladder, okay, it can be local spreads, it can be there lymphatics, it can be hemotogenous local spreads, it can spread to the gallbladder beds, adjacent part of the liver, that is liver segment 5, segment 4, and segment 5. It can spread to adjacent lymph node at the portal hypertus. Then it can also separate locally to adjacent structures like the duodenum, just part of the duodenum, and the stomach.
Okay. So this patient had a surgery and there was a laparotomy wound, and at the third postoperative day there was yellowish discharge. So what could be the reason for that?
This is most likely surgical site infection, most likely um, bacterial wound infection.
Okay, so what is the most common organism that causes this surgical site infection?
It's Staphylococcus aureus.
Okay, so the patient deteriorated, and after 2 to 3 more days the patient developed a dark discoloration of the wound with purulent discharge and hemodynamic instability. So what will you suspect now?
With this, I would suspect necrotizing fasciitis.
Okay. So can you name some organisms which causes necrotizing fasciitis?
Okay, fasciitis is a polymicrobial infection. So the organisms implicated are Streptococcus pyogenes, Staphylococcus aureus, uh, Clostridium perfringens, and Bacteroides fragilis. Those are the names implicated.
Okay. So how can you diagnose necrotizing fasciitis?
Yes, necrotizing fasciitis can be diagnosed clinically when there is extensive wound uh, with the presence of purulent discharge with discoloration. It might be foul smelling with destruction of the skin, subcutaneous tissue, and even the fascia. Usually, muscle is preserved. This is clinically. Then microbiologically, and then other things are clinically. Patient could have a toxic symptoms. Patient will have a fever, tachycardia, In severe cases, you might even have hypotension and confusion when sepsis has upset. In microbiologically, uh, uh, polymicrobial organisms can be found on microscopic culture sensitivity of the tissue when taken. These organisms that I just mentioned.
Okay. So can you tell us about the pathology of necrotizing fasciitis?
Okay, the pathology of necrotizing fasciitis is mainly gangrene, gangrene of soft tissue, skin and soft tissue with thrombosis of local arterial blood flow,
And how
blood thrombosis.
and how will you manage necrotizing fasciitis?
Yes, for necrotizing of fasciitis, this is critically ill patients on managed education according to care of critically ill surgical patient protocol. I will support the hemo, uh, and cardiopulmonary status of the patient. I will give him adequate oxygen, ensure uh, good airway breathing, then control the temperature, hypotension, uh, uh, yes, control the breathing temperature, hypotension to stabilize the patient. Then it's appropriate to monitor urine output. Example for baseline investigations, the arterial blood gases for blood count and differential. Then take sample specimen for microscopic culture sensitivity and commence empirical broad spectrum antibiotics, then debride the whole extensively.
Okay.
Whole debride whole extensively. When the culture sensitivity is out, then I might change the antibiotics according to the culture.
So who will you involve in the care of this patient?
Okay, in the care of this patient, I will involve ITU registrar, intensive care unit registrar, then general surgeon, plastic surgeon, yes, and likely the anesthetist.
Okay. So patient had debridement and was given extensive amount of antibiotics. And 9 days later, he develops bloody diarrhea. So what could be the differentials for post-operative bloody diarrhea?
Uh, in this which I'll first I think of Pseudo-Membranous colitis. Other differentials could be inflammatory bowel disease, uh, ischemic colitis, and this in yes, hospital acquired infective gastroenteritis.
Okay. So what is the pathogenesis of pseudomembranous colitis?
Okay, pseudomembranous colitis occur as a result of long use of uh, broad spectrum antibiotics that uh, impaired or that kill the normal flora, normal microbial flora of the gastrointestinal tract, thereby allowing the growth and proliferation of Clostridium difficile, which now uh, colonize the bowel and cause local yellow plaques and then ulceration, skip ulcerative lesions as the normal microbiota has been depleted by the long-term antibiotics use.
Okay. So how will you investigate pseudomembranous colitis?
Uh, I will do stool culture, microscopy, culture sensitivity, then uh, lower gastrointestinal endoscopy, sigmo, uh, I mean, and colonoscopy. So for the microscopy culture, it may culture the organism. Then for the colonoscopy, I may show that might show, that may visualize the patches, the yellow patches as plugs, and then multiple areas of hyperemia, redness of the mucosa.
Okay. And what will be your management for pseudomembranous colitis?
Yes, for Pseudo-Membranous Collitis for mild cases, I can give oral vancomycin, 125 milligram daily for up to 10 days. While for severe cases, I'll give up to 500 milligrams daily, and I'll combine with metronidazole, uh, 500 milligram metronidazole IV daily for up to 10 days, 10 days to for up to 10 to 14 days.
Okay.